All right. Before we get into the rhythms, the one thing we'll talk about is symptomatic versus stable. A lot of people with dysrhythmias are going to be symptomatic. They're going to feel short of breath, weak, lightheaded. They might have some chest pain, palpitations, things like that. Symptoms don't really differentiate between fast or slow dysrhythmias. Most people are going to feel the same symptoms regardless if their heart's beating at 200 or 20. The reason being, the dysrhythmias limit cardiac output. When they have lower cardiac output than normal, they're going to feel dizzy, lightheaded, things like that. So we don't really look at the symptoms and tell us what the heart's doing. We just know that people with dysrhythmias are going to be symptomatic. Next, we'll talk about stability. When it comes to stability, we normally look at blood pressure and we know if someone is stable or unstable. Hypotension means they're unstable. We don't have enough time to work because they're not going to be perfusing well. So when we look at rhythms, we want to know those two things. So the first rhythm up is going to be SVT. We know it's SVT because we have a normal QRS and a normal T. We just don't have any Ps. So we don't really know what's happening above the ventricles. But we do know that the ventricles are working normally. Our goal with SVT is going to be to slow it down to figure out what's happening under it. Could be a fib, could be a flutter, could be normal sinus tach. From there, once we get it slowed down, we'll know what we're working with. To slow it down, we have a few options. If this person is symptomatic and stable, we have some time. We can try our vagals, we can try our adenosine. The doses are 6 and 12. If they're unstable, we're going to look more towards cardioversion. We're going to do synchronized cardioversion. We want to make sure it's on sync, so we're shocking on the R wave, and we're not going to shock on a T and cause any other dysrhythmias. But our three lines of defense to this are going to be our vagals, adenosine, and cardioversion. Next up is going to be our bradyarrhythmias. Here we have sinus brady. With sinus brady, one of the biggest things we want to know, if this is where they live, if someone's normally brady because they exercise a lot and they just have a lower heart rate, we don't really have to do much. But if this isn't where this person lives, and say they're normally in 70s, now we found them at 40s, we want to start looking at what we can do to fix this. For sinus brady and other bradyarrhythmias, we're going to use our atropine, and we're also going to look at possibly pacing. Really depends if they're stable or unstable. If someone's stable, we'll try our meds first. If someone's really unstable with a pressure of 60/30, say, we're going to look more towards pacing to get that pressure back up and make sure they're perfusing well. After our Brady's, we're going to look at our VTAC. So here we have VTAC. When it comes to VTAC, the one thing we want to know before everything is, do they have a pulse? If they have a pulse, that's good. We have a little time to work here. With pulses, we're going to go to our synchronized cardioversion because we don't want to make them not have a pulse. If they don't have a pulse, we're going to look at our cardiac arrest algorithm. So we're going to try defibbing. We're going to go into our medications such as epi and amiodarone. And of course, before we do all of this, we're going to start CPR. With that, when we get into, say, our V-fibs, it's going to be the same thing. We're going to be working in our cardiac arrest algorithm. We want to make sure they don't, or we want to check a pulse. Chances are they're not going to have one. From there, we're going to start CPR. We're going to go back into our cardiac arrest meds, such as epi, amiodarone, and we are going to prep to defib this. The first thing that we can do for this is defib. It's going to be the most important thing we can do. Next up, we're going to move to our non-shockable rhythms for our cardiac arrest algorithm. So here you can see that we have asystole. Our other non-shockable rhythm is going to be PEA. We're going to run into the room, make sure, or check a pulse. They're most likely not going to have a pulse with this. So we're going to start using our meds such as epi to try to reverse this along with CPR. And we might look into our H's and T's, the same thing we would do with PEA. Lastly, we have our AFib. So You can see we're in AFib here. We have our RVR because we know we're at a very high rates. If this was, say, 85, we wouldn't be in RVR. We would have a lot more time. Most people with a slow AFib are usually pretty stable and not symptomatic. It's going to be more of a cardiology consult. When they have RVR, they might have symptoms. They might be unstable. So we're going to try to medicate this. We can use medications such as calcium channel blockers, beta blockers, so metoprolol, cardizem. If they are very unstable, we might go straight to cardioversion. The one thing we want to know about cardioversion before cardioverting is this new or old? If this is old AFib, we want to make sure they've been taking their anticoagulants, and we want to make sure they haven't missed any doses. If this is new AFib, we want to make sure that it's under a 24-hour window. Anything over 24 hours, it's most likely they've developed the clot. So if we cardiovert, get them back into a normal sinus, they're going to wind up throwing that clot, most likely having a stroke. If it's under 24 hours, it's unlikely that they've had long enough to develop a clot, so we can try cardioverting.